Good evening, everyone. This is the surgical track, and it's a pleasure for me to introduce it to all of you. I'm Dr. Mohammed Lemki from the Sultanate of Oman, one of the board members and founders of the association. So it gives me great pleasure today to introduce three prominent speakers from the surgical track. And the three topics they're going to cover is new surgical approaches for thyroid surgery, then the role of lymph dissection in thyroid cancer, being aggressive part of it. And last but not least, to avoid complication, introducing the topic of intraoperative nerve monitoring and management of voice changes after the surgical procedure. So the first speaker is assistant professor in endocrine and general surgery specialist, is Dr. Salman Al Safran from Kuwait, and he is holding a chair at the University of Kuwait and Mubarak and Jaber Hospital. The second speaker will be Dr. Mohammed Al Ghani from the Kingdom of Saudi Arabia. He's also assistant professor in King Saud bin Abdulaziz University, Riyadh, and is a consultant head and neck oncology surgeon. And his topic, as I mentioned previously, on the lymph node dissection in thyroid cancer surgical approach. The last of our prominent speaker will be Dr. Mohammed Ali from UAE, consultant head and neck surgeon from Sheikh Khalifa Medical City. And he will, as I mentioned, look after and enlighten us on intraoperative nerve monitoring during the procedure to avoid and also in the management of voice changes after surgery of the thyroid. So I like to, for housekeeping, 25 minutes for each speaker. And at the end of the session, we'll have 15 minutes of discussion. Thank you. The floor is yours.
Good evening, everyone. My name is Dr. Salman Al Safran. I'm an assistant professor of surgery at Kuwait University, chief of endocrine surgery at Jaber Al Ahmed Hospital. We'll be talking about today updated surgical skills in the management of benign thyroid nodule. First, I would like to thank the Arab Thyroid Association for the opportunity to present in the second annual Congress of Arab Thyroid Association. I have nothing to disclose. So how old is goiter? Was first described in around 2700 BC in the Chinese literature. And in about 1600 BC, the Chinese used a burnt sponge and a seaweed to treat goiter. So what about the history of thyroid surgery? Despite goiter has been an endemic in several parts of the world throughout history, there is little we know about thyroid surgery. The first recorded attempt for goiter excision was done in the 500 AD by Abu al-Ghassan in Baghdad. He performed the first recorded goiter excision. Despite massive postoperative bleeding, the patient survived. Moving forward about 450 years later, Abu al-Qasim al-Zahrawi, accredited with performing and describing the technique for goiter excision in his very famous surgical tome, Al-Tasrif. And then about 200 years later, in the school of Salerno, Roger Frugati and his group performed multiple goiter excision by using two heated cetone to excise the goiter. That time, the surgery was barbaric. The patient was completely awake, was held by an assistant, and did not gain any popularity. So looking at the screen left, this depicted from Al-Zahrawi Al-Tasrif book. And screen right, this is from School Salerno, Frugati and his group. As you can see, the patient was completely awake, held by an assistant, and the goiter was excised using a two-heated cetone. As you can imagine, this was absolutely barbaric. So from back then until the middle of the 19th century, technical improvement did not occur until the middle of the 19th century. And in the term period, appalling result led in the 1646 to imprisonment of a surgeon for his work and a total abandonment of thyroid surgery by the French academic medicine in 1850. Samuel Gross, a famous trauma surgeon of the United States, stated, "There is no honest and a sensible surgeon would ever engage in performing a thyroidectomy." So for a long time in history, thyroid remained in its infancy until the middle of the 19th century. Thyroid surgery came of age because of a new development as the use of ether for anesthesia, antisepsis in 1867, and the first effective surgical tools, or the artery forceps, in the 1870, which allowed unhurried and safer dissection. So modern thyroid surgery credited to multiple people. Out of those is Theodore Billroth. Theodore Billroth was regarded as one of the best surgeons in his era. He was very distinguished, was well known across Europe, had an attempt with performing thyroid surgery. However, his complication rate was 40%. This had led him to completely abandon doing a thyroidectomy. He later on during his career resumed doing the surgery with much lower mortality of 8%. Theodor Kocher, he's basically the developer of the current technique we use for thyroidectomy. He was so instrumental in performing a thyroidectomy because of his work for thyroid surgery and thyroid physiology. He was awarded the Nobel Prize in 1909, and he's one of the only 5 surgeons to ever win a Nobel Prize. He was such a meticulous surgeon. He had a mortality of less than 1%. He's the describer of the collar incision that we use nowadays, which is named after him, Kocher incision. He has a famous quote which says, a doctor who can operate, or a surgeon is a doctor who can operate and who knows when not to. As you can see in the screen right bottom, Kocher performing a thyroidectomy. As you can see, there's no antiseptic technique whatsoever. He's performing his surgery with a bare hand. So Theodore was such a meticulous surgeon. When he performed the surgery, he most of the time would remove the complete thyroid. Back then, there was no thyroid replacement. And this is a famous patient of Theodore Kocher, Maria. She was an 11 years old who underwent total thyroidectomy and post-operatively developed severe hypothyroidism. Back then, this entity was not well known. So as you can see in the picture on the left, Maria, the taller girl, and then 8 years later, you can see her younger sister outgrew her because she was severely hypothyroid. Because of her story, he completely abandoned doing a total thyroidectomy, and he was doing a subtotal thyroidectomy. Then moving on to William Halsted, who is a famous American surgeon who actually was a student of both Kocher and Billroth. His contribution for describing of the parathyroid anatomy and vascular anatomy. He had a famous say concluded by the supreme triumph of a surgeon art. What he meant to say is, to be regarded as an excellent or a distinguished surgeon, you should be able to do a thyroid surgery with no complication and mortality. In the 20th century, those 3 well-known surgeons, Charles Mayo, George Cryle, and Frank Leahy, they were well-known and well-regarded surgeons during their times, just because they were able to do a very safe thyroid surgery. Charles Mayo, he was the founder of the Mayo Clinic. George Cryle, he's the founder of Cleveland Clinic. Frank Leahy, he's the founder of the Leahy Clinic. So modern advancement in antiseptic anesthesia and surgical instrument and energy device have led to this advancement. And most recently, in the last 30 to 40 years, the utilization of intraoperative neuromonitoring have led to much safer surgery. So nowadays, what we do is sutureless and drainless thyroidectomy. What meant is we do not ligate any vessel. We do not put any drain for most of our thyroid cases. Thanks to the advanced energy device, we have the bipolar sealant device and the ultrasonic scalpel. So the surgical concerns throughout times, in the 19th century, the main concern was infection and bleeding. And in the 20th century was the hypothyroidism and the recurrent laryngeal nerve injury and the hypothyroidism. In the early 2001 century, cosmesis and incision is becoming the main concern. So this is the picture depicting the multiple way of performing an incision to perform the surgery. As you can see, there's multiple way, and in the screen right, this is the famous Kocher incision. We still utilize it nowadays to perform our thyroidectomy. So as you can see, and you can from this picture, with all those incisions, very ugly. And even when you make the incision very small, if you're prone to develop a keloid, a hypertrophic scar, you still have ugly incision, especially in the neck, something you probably can't easily hide. So the aim was initially safety, now safety and pretty. So this led for the future of surgery. So now what we do is, or what people have utilized to overcome the incision in the neck, something called minimal invasive thyroidectomy. Either we can do it through a smaller incision, 2 to 3 centimeter, video-assisted incision through the neck, or no-neck incision through either remote access or scarless, a node surgery. So minimal invasive video-assisted thyroidectomy, or the MIVAT, which basically utilizes a small incision in the neck, was popularized in Pisa in Italy by Mikuli and his group. They had an excellent result with the comparable postoperative complication and length of stay. His median lobectomy, thyroid lobectomy, was 32 minutes and a total 44 minutes. Then moving to the remote access thyroidectomy, we can do an incision away from the neck, either through the axilla or through the breast and the axilla. The first one is the transaxillary thyroidectomy, and the other one is the bilateral axillobreast approach thyroidectomy. As you can see, this will require a lot of dissection, will require a lot of training, and will have a learning curve. It's not easy to master. So nowadays, Ankun Anawang was a general surgeon in Army Hospital in Bangkok, has basically not invented, refashioned transoral thyroidectomy. He, in 2016, went through the natural orifice through the mouth and performed 400 cases, and he reported his outcome. And as you can see, his outcome were very comparable to the open technique, with a slightly longer operative time. And interestingly, despite going through the mouth, he recorded 0 infection in his first reported series. So to qualify for transoral thyroidectomy, the indication that's proposed by Ankun Anawang, which I actually spent some time with him in 2018 in the Army Hospital in Bangkok, you need to have a motivated patient. A patient would be prone to develop bad scarring, and the thyroid diameter should be less than 10, with the largest nodule should be less than 6 centimeter, with one of the following pathological criteria: either benign disease, multinodular goiter, or indeterminate thyroid nodule, or thyroid cancer with less than 2 centimeters with no lymph node metastasis. Contraindication would be previous neck surgery, history of neck radiation, retrostant extension, cancer of more than 2 centimeters, or coagulopathy. Nowadays, people have challenged those criteria and have actually done modified neck dissection through the transoral technique with the utilization of the robot. So to see which of our patients that will be eligible for transoral thyroidectomy for benign disease, our group in University of Chicago during my fellowship conducted a multi-centric study and looked at the first 1,000 patients that walked into an endocrine surgery clinic. Out out of those with benign disease, 70% will qualify for the transoral thyroidectomy. This paper, we actually published our first 5 cases that we performed in Kuwait. As you can see, only 1 temporary mental nerve injury and 1 seroma. Thus far, we've probably done more than 30 cases. So I've included a video to put everything together and to show you how we perform our transoral technique. Those are the proposed incision sites. We start with making the incision through the inner aspect of the lower lip. Then we insert our trocar. This is where we'll be standing. Then, similar to the open technique, we perform our sublatissimal flap. So screen top is the platysma, screen bottom is the strap muscle. Then we divide the strap muscle at the median raphe to expose the underlying thyroid. Once this is performed, the strap muscle retracted laterally, and as you can see, the thyroid is exposed. Then we use retraction stitches to retract the strap muscle away and to expose the carotid sheet. The thyroid is retracted medially. The loose areal tissue between the carotid sheet and the thyroid are divided. Then we divide the isthmus of the thyroid to expose the underlying trachea, which is, you can see, bottom of the screen, white. Then we identify the superior pole vessels, which are divided. In the process, you can see going across is the external branch of the superior laryngeal nerve, which is identified and protected. Then the berry ligament is divided, and the white structure next to the berry ligament is your recurrent laryngeal nerve in the right, which is protected here. Then the thyroid completely removed from the trachea, placed into an EndoCatch bag, and retrieved through the 10mm port. Then we check for hemostasis. Then we approximate the strap muscle. This is the final result after the closure. And this is our patient 3 weeks after surgery. So in conclusion, although the basic thyroid operation has not changed much in more than 100 years, technical and technological advances have improved our ability to prevent complication and to modify our approach to a thyroid gland. With this, I'll conclude the talk, and thank you again. I'll take any question.
Thank you for the elegant talk. We learned a lot. We'll keep the questions at the end of the session, if that is all right with everyone. Thank you. The next speaker, please, can take over and start.
Good evening, everybody. Assalamu alaikum wa rahmatullah. It's my pleasure to be with you today in the second Arab Thyroid Association meeting. I'd like at the beginning to thank the organizing committee and the scientific committee for giving me the chance to be with you today in this presentations. My talk today is about extent of neck dissection will differentiate thyroid carcinoma. My name is Mohammed Al-Garni. I'm the head section of ENT department, head section of ENT in King Abdulaziz Medical City, Jeddah. So I will start my talk about thyroid, extent of lymph node metastasis in thyroid carcinomas. I think everybody knows that there's a global rise in the thyroid cancer. And probably the reason for that is either we are detecting more thyroid cancers in our patients, or there's an exposure to more environmental risk, like iodine and so on. So there is definitely a rise in the discovery of thyroid cancer all over the world. In the United States only, we have 33,000 of cases of thyroid cancer discovered every year, and 10,000 and 1,000 deaths a year. That's really quite a big number of mortalities related to thyroid cancers. So this means that thyroid cancer is one of the important health problem all over the world. I will make my presentation very concise about very specific part of the thyroid cancer in general. So it will be about lymph node metastases. To start with, I would like to show you here in this picture that the pattern of lymph node metastasis generally in head and neck cancer. As you know that we are dividing the neck into 5 divisions. Level 1, which is in the submental area, level 2 and 3 and 4, related to the jugular vein, the upper, middle, and lower jugular vein. Posterior to the jugular vein is level 5. Metastasis of thyroids in the lateral neck. This is we call the lateral neck lymph nodes. And the patterns of metastasis of thyroid cancer to the lymph nodes is not equal. So each lymph node has its own luck in regards of metastasis from thyroids. But generally speaking, level 2, 3, and 4 are the most commonly involved lymph node. Also, level 5 is one of the other lymph nodes that is also involved in thyroid metastasis. But generally speaking, we can say that level 1, and which is submandibular area, does not have high prevalence of metastasis from thyroid cancer. So this is usually we don't include as a general rule level 1 in the dissection of the neck during neck dissections of metastatic thyroid cancer. Now, for the central compartment of the thyroid of the thyroid metastasis is actually composed from 4 components. First component is the central midline part of the central compartment, which include the perilaryngeal and peritracheal lymph nodes, which sometimes we call Delphian lymph nodes. The other component is the lateral to the trachea and the recurrent laryngeal nerve, central compartment, in the right side, and the other part is the same on the left side. And the last but not least, as part of the central compartment, is level 6 and level 7. Level 6, with superior mediastinum and mediastinal lymph node metastases. Now, one of the most important concerns in metastasis of thyroid cancer is micrometastasis and the effect of micrometastasis. I'll not go into the definitions of micrometastasis because there is also debate about its definition of micrometastasis. But generally speaking, less than 2 millimeters in the lymph node is considered as micrometastasis. Although some propose 3 and 3.5 millimeter in the lymph node to be considered as a micrometastasis. But what is the effect of micrometastasis in the prognosis of patients with thyroid cancer? Although micrometastasis is highly prevalent in patients with thyroid cancer, but the effect of the micrometastasis is still debatable. Although it has now a major effect on mortality and almost negligible mortality if you consider this, but it may affect the need to have adjunctive treatments post-thyroidectomy in patients with well-differentiated thyroid cancer. So micrometastasis generally does not affect mortality, but it may affect the type of treatments. While the effect of occult metastasis on prognosis is quite different, in some of the studies, it has been found that metastasis finding by perioperative ultrasound has a major effect on the prognosis of patients with well-differentiated thyroid cancer. The risk of recurrence has been found to be 2% if you have no positive lymph node metastasis, but it's about 22% if you have positive lymph node metastasis. I'm sorry, it's not occult metastasis, I mean overt metastasis. And this also helps the endocrine surgeons post-operatively to stratify those patients in regards of the post-operative adjunctive treatments. So lymph node metastasis, whether we have small number of lymph nodes have metastasis, or whether we have bigger size of lymph node with metastasis, this will help the endocrine surgeons in the post-operative period to stratify those patients to give or not to give ablation treatment. They divide them into whether low risk, intermediate risk, and high risk based on the lymph node metastasis and also the size of the lymph nodes. In regards to the central compartments, now this is the first most important part of my talk, is what to do for central lymph nodes in well-differentiated thyroid cancer. Within the central lymph node, central compartment, lymph nodes tend to have a more abundance, tend to be more abundance in the superior part of the isthmus. So the superior part of the isthmus are more abundance, but also the metastasis from thyroid cancer has some preference to lymph node in central compartments. The lower part go to the central lower part of the central compartments, and the inferior pool go to the lateral central compartments. But if you have superior pool tumor, usually they have some percentage of skip metastasis where they metastasize to the lateral neck without metastasis to the central compartment. This is why it makes sometimes you find some of your patients that they have metastasis at the lateral neck, but they don't have metastasis to the central compartment. Although this is not unusual. Most of the patients, they have, if they have central lateral compartments metastasis, they definitely have a central compartment metastasis. This is it's a complex picture to show you the pattern of metastasis of the thyroid cancer based on the location of the nodules, the cancer nodule in the thyroid. It's very complex, but generally I would like to say that if you have a superior pool cancer, those cancer, they metastasize more to the lateral compartments instead of the central compartments. So you have to consider skip metastasis in some types or some locations in the thyroid cancer. Now, if you have no lymph node metastasis detected in the central compartment perioperatively, and there is no also lateral compartment lymph node metastasis, what to do in regard to the central compartment? Or this is the most debatable part of my talk, whether to do lymph node dissection or not. Actually, we have a very different wide range of recommendations from different societies and cancer institutions. For example, in the American Thyroid Association in 2015, they only considered prophylactic neck dissection, central compartment neck dissection in patients who has T3 and T4 tumors, or if they have involvement of the lateral neck. So if you have T3 and T4 thyroid cancer, or if there is a lateral lymph node metastasis, prophylactic central neck dissections, even if there is no lymph node, is recommended. Same in recommendation, you can find it in the National Comprehensive Cancer Institutions, where they recommended to do prophylactic central compartment neck dissection if there is no metastatic detection detected by ultrasound perioperatively. We consider this in case of T3 and T4 thyroid cancer. British Thyroid Associations, they don't have any very clear recommendations, but what they recommend is to weigh the risk and benefits for patients with well-differentiated thyroid cancer. So if you have higher chances of benefits compared to risk, so you can do prophylactic dissection, but if the reverse is true, it's better to avoid central compartment dissections. If we go to the European Society of Endocrine Surgeons, they consider it also in T3 and T4. So if you have N0 central compartment, but you have T3 and T4 thyroid cancer, it's recommended to go for central compartment lymph node dissections. Also, they recommended other type of, or other patients, other high-risk patients. If you have a male patients, clinically positive lymph node metastasis, all these are recommendations or guidelines to help you to decide whether to do prophylactic dissection or not. For Japanese Society of Thyroid Cancer, they recommend to do it routinely. All patients with thyroid cancer, well-differentiated thyroid cancer, they recommended to do central compartment neck lymph node dissections in all patients, regardless of whether the lymph node detected preoperatively or not. This is just to show you how the progressions of recommendations over years in American Thyroid Associations. So in 2009, the recommendation just only to do central compartment neck dissection in case of T3 and T4, while it moves a bit where they recommend also to do it if you have lateral lymph node metastasis. 2015, they recommended that if the information gained from central compartments dissection is important and will help you to decide for further management, so you have to do central compartment neck dissections, but they recommended not to do central compartment neck dissections in case of T1 and T2. So T1 and T2 thyroid cancer is not recommended if there is no metastasis detected perioperatively or preoperative. So the debate comes as it's clear that the recommendation to do prophylactic neck dissections, central compartment neck dissections, and in high-risk patients. But it has been found that there is a trend toward central compartments neck dissection to avoid radioactive ablations, and this has been found especially in patients with high-risk tumor or high-risk patients, like large tumors, male patients, and extreme age, and other risk factors. So why the decision to do prophylactic central compartment neck dissection is not easy? These are some of the points showing you that what the difficulty of deciding to do central compartment neck dissection or not. First is because the tumor is low aggressive behavior of most well-differentiated thyroid cancer. And also there is a low chances of local regional recurrence rate, and there is irrelevant mortality in relations to metastasis central compartments. These points make the decision to do central compartment neck dissection not easy. But why it's still debatable, because we think we are more oncologically safe if we do central compartment neck dissections. And also we have to weigh the risk on patients, because the patient safety is exposed if you do extensive surgery like central compartment dissections. If you ask ourselves what's the goal of prophylactic neck dissections, is potentially avoiding the treatments, giving more treatments like iodine ablations in those patients post-operatively, and to minimize biochemical evidence of the disease and to simplify the follow-up. These are points that make us or help us to decide for or the goals of prophylactic dissection. But mind you that reoperations in recurrent thyroid cancer is not without complications. The chances of recurrent laryngeal nerve paralysis is about 18%. There's also chances of 24% to find the lymph node, the tumor invading the recurrent laryngeal nerve. So we have very clear goals in regard to prophylactic dissections and why we do it. But mind you that we have still higher chances of complications like vocal cord paralysis, which is most devastating complication of thyroid cancer. There are a few other important points to be considered regarding the recurrence and the information that we gain and the prevalence of metastasis and impact of the tumor in lymph nodes on prognosis of patients. These are all factors help us to decide whether to do lymph node dissection or not. The question comes again, why we have to do prophylactic dissection if it doesn't affect survival, does not affect the overall prognosis, and why I have to do it if it may increase the complication rates? These are questions that you have to ask yourself if you're deciding to do a central compartment neck dissections. In the literature, it has been found that it's definitely reduced the need to perform frequent iodine ablation for those patients. So probably we are not gaining a lot by doing prophylactic dissection, except that we are minimizing the chances of giving iodine ablation post-operatively or repeated iodine ablations. I think this is a very important goal for endocrinologists because of the complications of iodine ablations. But we have to remember that surgeons who are doing central compartment, they have to have experience in doing central compartment dissections because the chances of complication like hypoparathyroidism and recurrent laryngeal nerve is quite high. And there is still no clear definitions about experienced thyroid surgeons. I will show you another slide to show the mostly agreed minimum thyroidectomies per year to label a surgeon as an expert surgeon. So when you do a central compartment dissections, consider patients and tumors, like age of the patient, the tumor, the metastasis. But also remember that it has an extra cost to do central compartment dissections. And also the cost of recurrent engineered monitorings and the surgeon experience that need to be about 25 to 50 cases per year to label the surgeons as expert thyroid surgeons. We did a meta-analysis in our group in Jeddah to compare or to see the effect of prophylactic neck dissections in clinically node-negative papillary thyroid carcinoma. And we found the following. Regarding recurrence, we compare patients with metastasis and without metastasis, and we found no difference in the two groups, and the complication rate with doing thyroidectomy alone and prophylactic neck dissection also is very similar. We have no difference between the two groups. So although central compartment lymph node dissection is a safe procedure, but the recurrence rate and other problems that related to the prognosis is not different in patients with metastasis and without metastasis. Now, this is regarding the experience of the surgeons. There's a study that explored the when to label surgeon as an expert thyroid surgeons. And as you can see here, the odds of complications decrease with the number of thyroidectomy done by surgeons a year. So if you're doing one thyroidectomy per year, the odds of complications is 87%, while it's about 68% if you're doing 5 cases, 10 cases, only 40%, 20% if the surgeon is doing 15 per year. Now, if you're doing 25 or more cases of thyroidectomy per year, the chances of complications is almost approaching 0 and only about 3% other complications. So almost all surgeons agree that at least you have to do 25 thyroidectomies a year to be labeled as expert thyroid surgeons. This is an example of patients with central compartment, as you can see in the left picture, the left side picture, that the central compartment is cleaned from carotid to carotid. And on the left side, you can see the recurrent laryngeal nerve all the way is cleaned of thyroid tissues and also of the lymph nodes. And when we do this type of surgeries, we have to monitor the recurrent laryngeal nerve because the chances is high to injure the recurrent laryngeal nerve, especially the temporary paralysis of the vocal cords. So it's inexperienced surgeon is not difficult, but the surgeon has to have good training in doing central compartment dissection to avoid these complications. So for prophylactic neck dissection in the lateral side. Now, this is first part of my talk about central compartment. Now I'm talking about lateral compartment of the neck. Generally speaking, as a recommendations, we don't have any Western guideline recommending lateral lymph node dissections in patients with N0. So there is no prophylactic neck dissection, lateral neck dissection in patients with no metastasis detected radiologically in the preoperative period. We have only the Japanese Society of Thyroid Surgery where they recommended to do prophylactic lateral neck dissection in highly selected patients with high risk or high risk tumor or high risk patients. So N0 lateral neck, there is no recommendation to do neck dissections, except in the Japanese Society's thyroid surgeons. They recommend to do it in highly selected patients. Now, which lymph node to be dissected in the lateral compartment? It's because the lymph node dissection is quite extensive. If you include lateral neck and central compartments and the complication rate is high, you have to decide which lymph node you have to dissect. Now, in meta-analysis that has been done showing the metastasis of the lateral neck, it has been found that about 53% are metastasizing to level 2, and about 70% to level 3, and in 66 in level 4. So level 2, 3, and 4 are the most important lymph nodes with harboring metastasis from thyroid cancer. And there are a few studies that showing also level 5. Some of the studies show about 40% of level 5 metastasis. So I can say that lymph node that need to be dissected definitely in patients with lateral lymph node metastasis is level 2, 3, 4 and 5. Level 1 is very unlikely to be involved in tumor metastasis. In summary, I have to say that prophylactic lateral neck dissection is not recommended in any guidelines, especially the Western guidelines. And the therapeutic modified radical neck dissections or selective neck dissection is the recommendation if you have preoperative evidence that there is metastasis to the lateral lymph nodes. Selective neck dissection is level 2, 3, 4, and 5. And modified radical neck dissection is level 1, 2, 3, 4, and 5. But usually what we do is selective neck dissection in thyroid cancer because we don't include usually level 1 in the dissection of metastatic thyroid cancer. Not because of the complication, but because the chances of metastasis is very, very low compared to other parts of or other compartment of the neck. So selective neck dissection in lateral neck, 2 to 5 is the recommended for metastatic thyroid carcinoma. In summary, regarding central compartments, it is recommended to do it as a prophylactic if you have high-risk patient or high-risk tumors like T3, T4, or extreme age, or very unfavorable pathology. In this case, even if there is no lymph node metastasis in central compartments, you can do central compartment lymph node dissection, provided that you're an expert thyroid surgeon. And if there is positive metastasis in the central compartment, definitely it's recommended to remove the central lymph nodes as part of the procedures. Now, in regards of lateral neck dissections, it's not recommended to do prophylactic lateral neck dissections. Although the Japanese, they recommended to do that in highly selected patients. But generally speaking, we don't do prophylactic lateral neck dissections. Now, if there is lymph node metastasis evidenced in preoperative period, we have to do lymph node dissection, whether to do modified radical neck dissection selective. Most of the thyroid surgeons agree that selective neck dissection is the preferred method of neck dissection in those patients. That includes level 2, level 3, 4, and 5. By this, I come to the end of my presentation. I would like again to thank the organizing committee and the chair of the scientific committee for having me with you today. Thank you so much.
Thank you very much, Dr. Mohammed. That was an excellent talk, and you covered a very difficult topic. And I'm sure you will get a lot of questions in the question panel session. May I invite the next speaker, Dr. Mohammed Ali from the United Arab Emirates.
I'm Dr. Mohammed Ali, laryngologist and head and neck surgeon at Sheikh Khalifa Medical City. I would like to thank you for letting me participate in this second annual Congress of Arab Thyroid Association. My topic will be intraoperative nerve monitoring and management of voice changes after thyroid surgery. This is my outline. We'll start in our introduction to talk about vocal fold weakness and voice changes after thyroid surgery. We'll come to this photo later on. Well, for any thyroid surgeon, the most satisfying thing is to find the nerve and make sure it is intact and functioning well. I'll go through the recommendations regarding the voice in the American Thyroid Association 2015. This recommendation, it says prior to surgery, the surgeon should communicate with the patient regarding surgical risks, including nerve and parathyroid injury through the informed consent process, and communicate with associated physician, including anesthesia personnel, regarding important findings elicited during the preoperative workup. Also in the recommendation 41, which was a strong recommendation saying that preoperative laryngeal exam should be performed in all the patients with preoperative voice abnormality or history of cervical or upper chest surgery if the patient is known to have thyroid cancer with posterior extrathyroidal extension or extensive central nodal metastasis. Again, the preoperative assessment will be also depending on the history, physical examination, as well as the imaging. Please be alert that the incidence rates of preoperative vocal fold paresis or paralysis in the patients are up to 3.5% in benign thyroid diseases and up to 8% in thyroid cancer patients. And also, as we all are aware, the recurrent laryngeal nerve, which is the main nerve to the vocal fold and is coming from the vagus nerve, is different from the right side compared to the left side. It is longer in the left side and more straight or more vertical in the left side. In both situations, it goes to the tracheoesophageal groove before it gets into the larynx. Also, it's very important to note that the external branch of the superior laryngeal nerve, which is also coming from the vagus nerve, play an important role in the voice. And this is the tract of the recurrent laryngeal nerve. Be familiar with the variations, especially with the non-recurrent laryngeal nerve, as we can see in this diagram. The thyroidectomy steps, actually, those steps are important. We, as thyroid surgeons, we all are aware of them. There's a little variation from surgeon to surgeon. However, there will be a lot of tissue cutting until we reach the thyroid, which will include the subcutaneous tissue, platysma, strap muscle splittings, and also raising the strap muscles of the thyroid lobe. This is a patient who had total thyroidectomy last year, and actually he sent me his photo a few days ago, and it's barely visualized. Sorry, I mean the scar is barely visualized in his neck. The importance of this is the soft tissue handling. I'm showing the scar not to say that the scar cosmetically is very nice, but to say like the soft tissue handling, as it is important in the skin, it is also very important deep under the skin. Mishandling the tissue has higher risk of injury to the recurrent laryngeal nerve, which can be by direct cut or laceration, traction, thermal damage, crush, scarring. So as we are so meticulous about the handling the skin and skin closure, it's very important to do the same when we are working around the nerve. This recommendation, it is a strong recommendation actually to visualize the recurrent laryngeal nerve during the dissection. Steps should be also taken to preserve the external branch of the superior laryngeal nerve during the dissection of the superior pole of the thyroid gland. I will stress on the importance of this part, even that doesn't say visualization of the superior laryngeal nerve, but steps or precautions needs to be taken to protect the superior laryngeal nerve. There's a weak recommendation about the intraoperative neural stimulation, even that we know the importance of the nerve monitoring. Here are the tools that we need to do the intraoperative nerve monitoring. And this is the screen that we monitor the activity of the recurrent laryngeal nerve. So this diagram, it's very important to note that the machine of nerve monitoring, it works as a cycle or circle. It's similar to the electrical circle where you need to enlight a bulb, for example. When there's any interruption in that circle, the light will not turn on. So you have the stimulator machine here, and this is the stimulator. You touch the nerve, the signal goes through the nerve to the vocal fold. The vocal folds contract, trigger the sensors and the endotracheal tubes, and that sensor will send signals to the machine to say that, oh, the circle is, or the loop is closed and the nerve is intact. And As you can see, the red oval area is the area that we want to be sure that is intact. However, if you watch this one, we are seeing the distal part of the recurrent laryngeal nerve. Just remember that we have to be alert about the proximal part of the recurrent laryngeal nerve. And this is a very important topic. As laryngologists, I get patients coming with a report saying that the the recurrent laryngeal nerve was not injured and was tested with the stimulator and was working. However, immediately post-op, the patient has vocal fold immobility. It's concerning that this area between the vagus nerve and the area that was tested probably was injured, but was not included in the testing. There are different levels of testing the recurrent laryngeal nerve, starting from the pre-op till post-op. The most important part, if you are in doubt, is this one, stimulation of the vagus nerve after achievement of the hemostasis control, just before closing the wound. So important to have the right tools, the nerve dissector, a cape tool, or even mosquito tool, and to use it in the right way. I'll mention an important point here. Nerve dissector, when you put it in the tissue, you have to be on the nerve. Don't leave any layer or fascia between the nerve and the tip of this dissector. You open the dissector while you are going into the tissue. You do not close the dissector blindly because it might crush the nerve. Magnifying loops, these are helpful. I use 2.5 magnifying loops, but you can go up to 3.5 or even up to 5. Other surgical tips. Avoid cutting any tubular structure before identifying the recurrent laryngeal nerve. It looks like vessel, but it might be a nerve. Be aware of the thermal damage by the bipolar near the nerve. I actually decrease the power of the bipolar, and I use microbipolar when I'm working in the nerve territory, cooling as needed. If you think that you cauterized tissue close to the nerve, cool it with wet gauze. Blunt transfer of the nerve with peanut. So whenever the nerve is like really adherent to the thyroid gland, see if you can push it a little bit with the peanut. Pushing it away 2 millimeter or 3 millimeter will make big difference. Avoid forceful compression and suction on the recurrent laryngeal nerve. And as we talked earlier, tissue handling, I prefer to use thinner forceps like Gerald forceps rather than DeBakey, and only picking tiny part of the tissue. Don't pick a big amount of tissue which might have the nerve in it. Hemostasis control. The better the hemostasis control, the better chance of identifying the nerve. The vagus nerve. When you have doubt, go to the vagus nerve and test the vagus nerve. The Zucker candle tubercle. This one has advantage, but also can be a disadvantage. The advantage of the Zucker candle tubercle, the recurrent laryngeal nerve course is medial to 93%. However, if this tubercle is so big, then it's also not easy to dissect the nerve under the tubercle. It's very important to check the whole recurrent laryngeal nerve if you are not exposing the vagus nerve. It's not enough just to test the distal part of the nerve, because the proximal might be injured and the machine will still tell you that the nerve is working. And look here, I'm gonna as I pointed here, it's very important to go to the most proximal or most inferior part of the recurrent laryngeal nerve that you expose. Make sure that is intact. If in doubt, go to the vagus nerve. This case was still not done, so I did level 6 neck dissection. Those are lymph nodes, unfortunately, around and under the nerve. And thanks God, the nerve was intact, functioning very well at the end of the surgery. Also, there's continuous intraoperative nerve monitoring, which is basically not just identifying the vagus nerve, but to connect it to the nerve stimulator machine and testing a bigger circle rather than the circle that includes the recurrent laryngeal nerve, but this will include the vagus nerve and the whole recurrent laryngeal nerve. And in this approach, you are checking the amplitude and the latency. the amplitude, if the amplitude falls below 50% of the value compared to the initial setup, this would be alarming. Also, the latency, if the latency increases by 10%, this is also alarming. There are sub-studies that showed that permanent recurrent laryngeal paralysis is significantly reduced by continuous intraoperative nerve monitoring compared to the intermittent intraoperative nerve monitoring. Again, I showed this diagram earlier, but with a different area of stimulation. So instead of stimulating the recurrent laryngeal nerve, we go back here and stimulate the vagus nerve. So we are covering the whole area of recurrent laryngeal nerve, starting from the vagus all the way to the vocal fold. And if the circle here is intact and our system is working well, then the circle is closed here and the machine will give you signals. What would be the reasons for false positive nerve monitoring? Which basically means that the nerve is intact and working, but the machine is telling you that's not working. Well, first, device technical problems. Check always the endotracheal tube, make sure that's in the right position, the connections, the wires, blood or fascia over the nerve, neuromuscular block, so relaxant. What are the reasons for false negative intraoperative monitoring? Which is basically telling you that the machine is telling you that the nerve is giving the signal, it works. However, in reality, after surgery, you find that the nerve is not working or the vocal fold is not moving. Well, as we described earlier about the proximal and distal parts of the recurrent laryngeal nerve. So if the proximal part of the recurrent laryngeal nerve, which is the most inferior, is injured, but you are only testing the distal one before it gets to the larynx, you are missing a part of the nerve assessment. Or nerve injury prior to the closure. So if you tested the nerve and found it, just make sure that after the last cut or last step dissection or cleaning or washing, make sure that before closing you test the nerve. Delayed neuropraxia, like edema that happens during the surgery or immediately post-op. Changing the blood supply if you are dissecting, let's say, Hidable 6 lymph nodes and you are skeletonizing the nerve, you are decreasing the blood supply to it, which can affect on its function. Or it can be non-neural, like arytenoid cartilage dislocation from the intubation. Also, as we mentioned earlier, be aware of the superior laryngeal nerve and its external branch. It innervates the cricothyroid muscle, and this is the only muscle that is being innervated by a nerve rather than the recurrent laryngeal nerve. This nerve also innervates the anterior 1/3 of thyroarytenoid muscles, which is adductor muscle, in 41 to 85% of people. It's called the human communicating nerve. And also it does anastomosis with the recurrent laryngeal nerve. So as I mentioned earlier, the guidelines are not saying that you need to visualize the superior laryngeal nerve or to use the nerve monitor for it, but you need to take precaution to protect it when you are working on the superior pole of the thyroid. How to protect it? Now, if you are working there and you find the nerve, perfect, this is the best. Preserve it. Do all steps and precautions to preserve it. But if this branch is not visualized, you don't have to dissect and find it. However, stay close to the thyroid capsule at the superior pole as possible. Skeletonize the superior vascular pedal, and you see those vessels before putting clips. Make sure that the nerve is not with it. Or use the intraoperative nerve monitoring. How many surgeries should the surgeon do every year to be considered as a safe surgeon for doing thyroidectomy? There are a lot of studies with variations about this, but one of the recent studies a few years ago, when about 16,000 thyroidectomy surgeries done in Duke University, found that the risk decreased significantly after more than 25 total thyroidectomy per year for the surgeon. It's very important to choose your surgeon when you're doing surgery. And as you can see, there are surgeons who are doing one case per year, and the risk increased by 87%. Now, after the surgery, patients should have their voice assessed in the postoperative period. Formal laryngeal exam should be performed if the voice is abnormal, and this should be done between 2 and 4 weeks. Important intraoperative findings and details of postoperative care should be communicated by the surgeon to the patient and other physicians who are important in the patient's postoperative care. That will include the phoniatric surgeon if the primary surgeon is not a phoniatric surgeon. How do you assess the voice subjectively post-op? There are different tools to assess the voice. Actually, I use the Voice Handicap Index 10, which are 10 questions, and each question scores between 0 and 4. 4 means the worst score, and 0, never. But the total number will be 40. And when we look at those numbers out of 40, so anything more than 30 will be considered as severe. 20 to 30 out of 40 is moderate. 10 to 20 is mild. Less than 10 is not significant voice problem. The first treatment for the voice change after thyroidectomy, if it happens, is conservative voice therapy. There are special consideration for the voice therapy, which will be done by the voice therapist. The orientation will be hygienic, vocal hygiene, hydration, voice rest, or symptomatic, chant talk, ear training, head position, pushing approach, or physiologic like vocal function exercise, resonant voice therapy. You really need a good SLP who has experience on voice therapy. Now, remember when I said that soft tissue handling is very important. Remember that the voice problem is not only because of the injury to the recurrent laryngeal nerve. Also, there are laryngeal extrinsic muscles, including the strap muscles. And those, you split them vertically when you are going down to the thyroidectomy, and then you close them. Just make sure that you handle them really well. And if you cut the muscle horizontally for big thyroid glands, also need to close it layer by layer. The effect of the laryngeal extrinsic muscles, the damage or injury or scarring, is a change in the pitch and loudness. And the treatment will be mainly muscle relaxation techniques and muscles strengthening techniques by the SLP. The laryngeal intrinsic muscles can be affected, and this is more due to the nerve injury or partial injury, and the voice will be breathy, weak, and can be a raspy voice. Head and neck stretching and relaxation techniques can help with this. It can be also not related to the surgery, but due to the intubation damage to the vocal folds, or irritation or edema of the vocal folds, vocal hemorrhage. Actually, also vocal granuloma, or we call it pressure granulation, which happens in the vocal process. Actually, I had 2 or 3 cases that they got granulation, granuloma over the vocal process post thyroid or parathyroid surgery. 2 out of the 3 patients, I need to take them back to the OR once the conservative management failed to treat them. The surgical management of recurrent laryngeal nerve. And it's very important to differentiate between unilateral or bilateral nerve injury. If it is unilateral nerve injury, the voice will be weak, breathy, and sometimes ends up with muscle spasm and tension due to the more efforts that the patient put to project his voice. The treatment can be, we can do the conservative management with voice therapy, but also the other options are injection laryngoplasty of augmentation material into the vocal folds to give him bulk and help to close the glottic gap and make the voice stronger. Or medialization thyroplasty by making incision in the neck and put an implant, or re-innervation. This is an example of a patient who had left vocal fold immobility. Actually, this was after carotid body tumor embolization and surgery. So you can see here that the left vocal fold is not moving. If you focus here, you find that the right vocal fold is trying to compensate. However, there's still glottic gap, which makes the voice of the patient weak. And actually, this is the same patient after injecting care left vocal fold. You will see here that I overcorrect the vocal fold, so it's not straight, it's over augmented, and that's in general recommended, especially if the patient does not have a breathing problem or lung disease. This is the medialization thyroplasty, which is considered as laryngeal framework surgery. So you make a window in the thyroid cartilage after making a skin incision, and through that window, we put an implant to medialize the vocal fold. Usually we use Gore-Tex or silastic material. Also, at the same time, arytenoid adduction, which will medialize the vocal fold, can be considered. The re-innervation technique. So there are different ways of doing this. If the nerve injury is identified by the surgeon, the best is to do direct anastomosis, nerve end-to-end nerve anastomosis at the same sitting at the same time. If there is a missing part of the nerve due to tumor, for example, but you do see the proximal and distal part of the recurrent laryngeal nerve interposition is an option. So you get a nerve from somewhere else, like ansa cervicalis or greater nerve, and do interposition nerve anastomosis. If you can't find the proximal and too much damage, then one of the options is nerve transfer, and the common one is ansa cervicalis, which innervate the strap muscles. You move it and do anastomosis to the distal part of the recurrent laryngeal nerve. This is less commonly done. If you can't find the distal part of the recurrent laryngeal nerve because of being damaged by, let's say, thyroid cancer, one of the approaches is doing the nerve muscle pedicle. So you get the ansa cervicalis nerve with a small part of the sternohyoid muscle that it stimulates or it contracts, and move it all together and put it into the larynx by making a window in the thyroid cartilage and put it where the vocalis muscle is. And with some with extensive voice therapy post-op, the patient will get some mobility of the vocal fold and improvement in the voice. Now, I'm not going to talk too much about the bilateral vocal fold immobility, as it is a different topic. Its effect in the voice is not significant, but it's very dangerous, very risky. So if the surgeon is getting a problem with the vocal fold mobility on one side, he ideally should not proceed to the other side the same sitting. You can stage the surgery and close into the other side in a different time. Doing both sides, and you know that the first time you injure the nerve has a risk of injuring the other side, and bilateral vocal fold immobility will cause a breathing problem, as the vocal fold will not abduct for breathing. And very concerning this, as it might end up with tracheostomy. There are some techniques that help to avoid tracheostomy, and if the patient comes to me, I go through this. If we think that the nerve is intact but not working, there's hope that will move. We can consider lateralization stitch of the vocal fold. Like here, this is a patient, unfortunately, who had hemithyroidectomy and completion thyroidectomy 6 weeks in between, and unfortunately both nerves were injured, and she has struggled with light activities. She was managed for a few months, but she was struggling and there was no improvement. So I did for her recently actually lateralization of the weaker vocal fold, or the less chance of recovery vocal fold. This was done for the right vocal fold. You see those stitches there on the vocal fold, and this after tightening them, so it did open the airway. We are hoping that she will get some recovery, but if she doesn't get recovery, we might need to go for more ablation surgery, which is chordotomy by cutting the vocal fold, or chordectomy by cutting a piece out of the vocal fold, or going for arytenoidectomy, which is taking part of the arytenoid to make the airway more patent. However, we need to know any of those opening the airway has a negative impact on the voice. or unfortunately, this is one of the solutions, but it is life-saving. If none of the earlier procedures that I mentioned are available in that center, in that region, patient probably will end up in tracheostomy, especially if it is not planned and if he's getting some respiratory distress, or let's say upper respiratory tract infection, lower respiratory tract infection, and ends up in the emergency department late in the night and somewhere that they don't have tertiary service or laryngologist, then the patient will end up with tracheostomy as a life-saving procedure. At the end, I would like to thank you for giving me the chance to speak on this important topic for me. And if you have any question, I'm happy to answer. Thank you very much.
Thank you very much for all the speakers. This has been a very elaborate, very highly technical topic. The first question to the panel for Dr. Safran about ecchymosis. How often you see ecchymosis in the new technique?
Hi, everyone. I would like to commend my predecessor speaker, Dr. Mohammed Al-Garni and Dr. Mohammed Al-Ali. Was very informative talks. Ecchymosis, we don't see it much, honestly. Sometimes when we are very superficial, we get some ecchymosis basically at the angle of the front jaw, but very rarely we get them. Unless the patient sometimes develops some bleeding subcutaneously, then you'll get ecchymosis. But honestly speaking, most of our patients, they actually do very well. And then some of them would actually go home the same day.
There are no other questions, so as a panel, I will ask a question for the three of you. How do you operate as a special purpose vehicle or workflow of your patients? We know we endocrinologists, we send patients for surgical procedures, but then sometimes there's no sort of MDT. Do you have an MDT flow for all your patients that he goes through the technique? Then you decide as surgeons to do a very aggressive operation. And of course, Dr. Mohammed Al-Ali to make sure that the procedure is done safely for the patient. And just to add some cream on my question, what is your thoughts after hearing Professor Yuri about using genetic testing to sort of prognosticate your surgical procedure? To all of you.
Can I say something? Can I answer?
Please go ahead.
Yeah, first I would like to thank the organizers. I would like to thank you, Dr. Lemki, Dr. Safrani, and Dr. Garni. For our institution, if the thyroid is straightforward, we do not discuss it in the MDT. We do have regular MDT. If there's any questionable approach about doing, for example, total or hemi, or total with or without central, I do take the case to the MDT pre-operatively, and we discuss it to get the consensus on the plan. But there are a lot of cases that are not being discussed pre-operatively. If I would say it straight. Having said this, of cases that roughly out of 10 cases, I have 2 or 3 cases that I discussed pre-operatively in the MD. Yeah.
Any other take on?
Mr. Chairman, thank you very much for you and all our panelists. As Dr. Ali mentioned, regarding the straightforward thyroid, usually we take them to go.
I'm frozen. I can't hear anyone.
Sorry, can you hear me? Dr. Lamki, can you hear me?
Yes, I can hear you now. I can hear you.
Yeah. So, as Dr. Ali mentioned, that we don't don't take straightforward patients to the thyroid board, for example. but we operate on them immediately. And once there is a problem, we discuss them in the thyroid board. Most of the cases I've discussed in the post-operative period in our institutions. This is in regards of the multidisciplinary team approach for those patients. The other question, Dr. Lemke, is?
After hearing Professor Yuri about genetic testing, do you use this new information for prognostication of your patient prior to surgery as you plan surgery?
Yeah, we do for pathologists. For sometimes they do genetic testing in indeterminate cases. If you have case that is indeterminate, so they send for genetic testing. That will help to decide whether to do hematopoietic thyroidectomy, especially in ulcer floss patients or patients with follicular neoplasm that they are high-risk patients. So we send them for genetics. Then from there we go whether to do hemothyroidectomy for the patient. Yes, it does help, but not in all cases, in certain cases.
Thank you. What about Kuwait? How do you do things over there?
So in Kuwait, what we do is majority of our patients, they're actually referred by our endocrinologist. And if a case needs a further discussion, we discuss it preoperatively, specifically for advanced thyroid cancer or something with unusual. When you have something anaplastic or we have something poorly differentiated or medullary thyroid cancer, we normally discuss them in the MDT. We have regular MDT where mainly we discuss the post-operative cases, but occasionally we have a preoperative cases we discuss ahead of time. With regard to the genetic testing, what we do is for the molecular testing, we don't do it routinely for the indeterminate nodules, mainly because of availability and logistics. We have only one person, and it takes very long time. But with regard to the genetic testing for a patient with family history of thyroid cancer, we actually refer the patient for our geneticist. He's one of our pathologists. And then they actually run a few tests. And if the patient is high risk, we'll get them tested, especially for those patients who have medullary thyroid cancer.
Right, gentlemen, colleagues, thank you very much. I have no questions from the audience, and I thank you again. It was a fantastic, very elaborate, very technical, something that we clinicians sitting there, we don't really appreciate. We think you are only butchers. So I think you're highly technical and appreciate what I've heard today. Thank you very much. And I close the session. And all of you, you have been within time. Actually, Dr. Safran, you did it much quicker than the rest, but it was all within time. And if, there's plenty of time for other questions, but unfortunately, I don't have any. And none of our surgical colleagues have put questions up to you.
Doctor, can I ask a question for my colleagues?
Yes, definitely.
Dr. Al-Ali and Dr. Al-Qarni, do you do routine vocal cord assessment pre-op for normal patient with no voice change or anything?
For me, yes. All patient has to have vocal cord assessment pre-operative, yes.
For me, yes. Voice assessment and laryngoscopy. Even that the guidelines that doesn't like a stress on doing laryngoscopy, it says like voice assessment and some exceptionals to do laryngoscopy. I think we should do laryngoscopy in every pre-op and post-op. And document.
Okay, so, yeah, because where I trained, we only did them when there is a voice change. When I came back to Kuwait, the anesthesia would not put the patient to sleep unless we have a vocal cord assessment. The other question I have for both of you is, do you routinely use nerve monitor for every thyroid case?
For me, the continuous monitoring, not in all cases, in selected cases. But I think there is a high risk for paralysis, or I need to monitor the nerve during dissections. But for all of them, for all cases, without straightforward cases, I do interrupted nerve monitoring. So continuous monitoring selected, interrupted monitoring for all cases. This is in my practice, in my personal preference.
For me, I mean, I was trained to do both with nerve monitor and without nerve monitor. I was trained in different institutions. But since I joined the current institution, I use the intermittent nerve monitoring. We do not have continuous nerve monitoring in my current institution.
And then when I came in, I didn't have the nerve monitor. So I had to do most of the cases initially with no nerve monitor, but now I do almost exclusively all the cases with nerve monitor. The other question is, do you use vagus nerve before, like, do you do the vagus nerve first and vagus nerve last stimulation? What I meant is before you do any dissection, you test the vagus. After the last step, you do the vagus. Is that something you do routinely or not?
Yeah, for continuous monitoring, yes, we have to do this all the time. So continuous monitoring, then I test it also with the probe, vagus nerve. This is for continuous monitoring. For interrupted monitoring, I don't do vagus unless there is I think there is an injury to the nerve. Because, you know, if you tested the nerve proximal to the injury, it may test positive and distal may test negative. So if I think there is a problem, I do vagus to be sure that 100% the nerve is intact. So I do it if I have a question, but I don't do it always.
Yeah, I'll concur my colleague. I do not expose the vagus nerve routinely. As we said, if preoperatively the vocal fold was functioning, I do not expose the vagus nerve at the beginning of the case. However, I had been through cases that I had, as my colleague said, some doubt in the recurrent laryngeal nerve. So I exposed the vagus nerve, I stimulated the vagus nerve.
So if there's any more questions, we still have time. We still have another 10 minutes or so till 8:30. It's been invigorating. I'm learning from the surgeons. That's great. Any more questions, gentlemen? Amongst yourselves. I'm not only the moderator today, I'm learning from you guys. Yeah. So I'll go after my surgeon.
So with regard to the vagus,
doing, yeah.
Yeah,
Dr.
Lamik, so I just want to mention,
consensus.
yeah,
And it should be followed via joining the Pan-Arab Thyroid Association. If there's nothing, then I'll. Yes, Dr. Safran.
Yeah, so what I do is, I don't expose the vagus nerve per se. I would go blindly between, like, just lateral to the carotid, and then I would just look for a signal rather than dissecting. So what I do is, after mobilizing the carotid sheath, I would put the nerve monitor there blindly. I wouldn't go dissection, and then get a signal. And then at the end of the case, I would do exactly the same maneuver. I do not dissect the vagus nerve or open the carotid sheath at all.
For me, even if I need to test the vagus, I don't dissect it. I agree with Dr. Safran. I just increase the voltage of the stimulator, then I go in between the carotid and jugular vein and test the vagus nerve without exposing the vagus. So this is in case if I have a doubt that there is injury, or I'm not sure that the recurrent laryngeal nerve is stimulating positive or not. So yes, Dr. Safran, I agree with you. We don't do dissection even if you are testing the vagus.
And then what about a drain? Do you guys put routinely drains or no drains?
For me, almost 95% no drains.
It depends on the case for me.
I have a question for you guys, if I may interlude a question about the prophylactic central compartment lymph node dissection. You have shown that the approach does not give any benefit as much as what we expect. The British, point of view, they're not so sure. The Japanese are very sure to go and do it. So, to the three of you, what is your practice? I mean, if you have a case, let's say, of medullary thyroid cancer, will you do both central compartment and lateral compartment dissection?
So for medullary thyroid cancer, it's basically, there is, again, it's very contralateral. So for medullary, you would do a total, a minimum is central for all the cases. The question comes with regard doing the lateral. dissection. Because once it goes to the central, probably it's already bad. So for the medullary, routinely, I would do a total with central. Lateral, I would not do unless there is like positive signs, positive lymph nodes, or the CEA and the calcitonin are very, very elevated, more than 500. I haven't seen many cases during my fellowship. I've seen about a couple of cases in Kuwait, and this is what I've been doing. I would be interested to hear from my co-panel.
Yeah, for regarding medullary thyroid carcinoma, if the tumor is small and it's not a familial type of medullary thyroid carcinoma, the minimum I do, and it should be unilateral, the minimum is total thyroidectomy, central compartment neck dissection, both sides. Now, if the tumor is big or it's familial type, or there is a positive lymph nodes in central compartments, I do total thyroidectomy, central compartments, and I do lateral compartment neck dissections. So it depends on the situation, the type of the tumor, familiar or not, the size of the tumor, and also presence or absence of lymph node metastasis. So these are for regarding medullary thyroid carcinoma. Regarding the PTC, or well-differentiated thyroid carcinoma, as Dr. Lemke said, I don't do central compartment neck dissection unless patient is high risk or the tumor is high risk. If the tumor is big, large, or the patient is old and there is vocal cord paralysis, and even if there is no lymph node metastasis, I do central compartment. Once there is a lymph node in central compartments, definitely I have to do both side compartments dissections. And in this case, I do continuous monitoring of the recurrent laryngeal. This is probably one of the situations that I have to do central continuous nerve monitoring.
For me, yeah, for medullary thyroid cancer, yes, central neck will be done. And as we said, this is prophylactic. So we are talking about the cases that are not confirmed with central neck metastasis preoperatively. If it is T3, T4, extrathyroidal extension, or high risk, yes, I'll do central neck. If it is confirmed preoperatively as thyroid cancer, as T1 or T2, then most probably I will not do central neck, unless if it is intraoperatively found suspicious lymph nodes. I do actually palpate for the cervical, for the central lymph nodes intraoperatively, even that it was confirmed preoperatively as T1 or T2 thyroid cancer.
Thank you, gentlemen. So if no other questions, then I don't have any from the audience. I've tried my questions. I don't know if you have any challenges amongst yourselves. You have 2 minutes. If not, I salute you. And I thank you for this wonderful, entertaining, educational interchange. And I've learned a lot from you. Thank you very much. And I close the session. Thank you. Saddam.